Hello everyone, hope you're all doing good. This is Dr. Agalya, your Organic faculty, and in this video we are continuing our discussion of Carcinoma Ovary. So next tumor is germ cell tumor. From the name itself you should be able to get. So these arise from the primordial germ cell of ovary. Okay, and among all the malignant ovarian cancers, germ cell tumors which are malignant will constitute only about 3% of cases, and it is mostly seen during childhood and young adolescent age. Okay, since they are mostly diagnosed at early stages of life, you should offer them fertility sparing surgeries only. These tumors have high chemosensitivity, and also know that dermoid cyst is the most common variety of germ cell tumor, which constitutes about 95% of germ cell tumors. Okay, then according to the degree of differentiation, germ cell tumors can be classified into two types. Number one is under differentiated germ cell tumors. This will include your dysgerminoma and gonadoblastoma, like that. And second one is differentiated germ cell tumors, so which will include all the other types of germ cell tumors. Clear? Now let's also quickly rewind all the different types of germ cell tumors. So classification. First one is dysgerminoma. Then we have the endodermal sinus tumor or yolk sac tumor, embryonal carcinoma, polyembryoma, your choriocarcinoma also comes under this category. We have teratoma as well. Teratoma can be immature teratoma or mature teratoma, as well as it can also be solid or cystic teratoma. Okay, so among this, where stands your dermoid cyst means it is a mature cystic teratoma. Okay, and this can also sometimes go for malignant transformation also, right? Then it can be monodermal or highly specialized. Okay, so another classification is can be monodermal or highly specialized. So highly specialized types will include your, yes, it is your struma ovary and carcinoid types. Okay, there can be mixed types also. Okay, so any combination can also be present, right? Now let's discuss about the tumors that is consisting of germ cells and sex cord stromal derivatives. Okay, so both components are present in gonadoblastoma and then mixed germ cell sex cord, stromal tumor. Clear? Right. Now, let's discuss about the clinical features in germ cell tumor. Clinical features. These tumors are asymptomatic in 1/4 of the cases. They can present with acute abdomen in 10% of the cases. Some cases can also present with chronic abdominal pain. There can be menstrual abnormalities also. Okay, menstrual abnormalities also. For example, in gonadoblastoma, there can be amenorrhea. Okay. Then, some tumors can present as pelvic mass. So, because of that, the patient may complain of abdominal distension also. Then, in advanced disease, advanced stage of the disease, there can be ascites or pleural effusion or even organomegaly. Okay, and since these are ovarian tumors, there can be a pedicle also, and pain can be acute due to the mass effect or torsion or even due to hemorrhage. Okay. Apart from this, one important presentation you have to remember is para-neoplastic syndromes. Para-neoplastic syndromes. So, which tumors will be present like that? Yes, stroma ovary. So, in stroma ovary, what we have? We have a, yes, teratomatous thyroid tissue. So, the cyst here is consisting of mature thyroid tissue. So, that will present as hyperthyroidism. Okay. Then, there can be hypertension as well from renin producing teratomas and hypoglycemia can be seen if there is insulin production, as well as autoimmune hemolytic anemias can also be seen. Okay. So, this much of paraneoplastic syndromes are possible with germ cell tumors. So, whenever you want to examine this woman, okay, remember she is a young woman, mostly unmarried. So, you have to offer her examination under anesthesia. Okay, because vaginal examination is not allowed. Clear? Right. Okay. Now, let us discuss about what are the other investigations you want to do in this female. So, the other investigations, because we are excluding TVS. Okay, that's why I mentioned the word other investigations. So, we can do USG, obviously transabdominal sonogram, or a CT, MRI. Okay, you can even offer her a color Doppler because we can find the vascularity of the tumor if she is presenting as acute abdomen to rule out torsion. Then you can do a chest X-ray to rule out metastasis as well as pleural effusion. Okay. So, apart from this, yes, we are coming to one important area. We can also offer serum markers to diagnose the tumors. Okay. So, the most commonly given serum markers will include HCG, then LDH and AF. Okay. But the combination of showing positivity to these serum markers will change according to the tumor type. Now, let's discuss that. So, first if we take this germinoma. It is positive for LDH and HCG. Clear? Then endodermal sinus tumor, and also here immature teratoma are going to show positivity to AFP and LDH. Okay. Then we have embryonal carcinoma, polyembryoma, or a mixed tumor. Okay, wherever you get embryo or mixed, that means many cell types are present, then these types will be showing positivity to all the three tumor markers, that is AFP, HCG as well as LDH. Okay, and one tumor, okay, especially choriocarcinoma, will be positive only to HCG, right? Yes. So that's all. So this is all about serum markers. This is one important slide. So many MCQs and Viva questions will be coming from this area, right? Yes. Now let's discuss each tumor separately. Okay. First, let us start with dysgerminoma. I told you which is the most common germ cell tumor. It is the dermoid cyst. Dermoid cyst is a teratoma. So dysgerminoma is the second most common germ cell tumor to occur, and this may occur from any age. Okay, so it can start right from infancy to 10 years also. Okay, and it can be seen up to early adulthood. Okay, yes, and dysgerminoma is mostly bilateral in 15 to 20% of the cases. Okay, so if you see the gross appearance of dysgerminoma, the size of the tumor is roughly between 5 to 15 centimeters. It is firm, fleshy, cream colored or a pale tan colored in cut section, and the cut section is usually lobulated. Okay, then dysgerminomas usually consist of cells that is not well differentiated or undifferentiated. We have seen this point in the beginning itself, right? So this is how the gross appearance of dysgerminoma will be. So you see there are so many lobules, okay, and it is pale tan in color. Okay, and you have to understand that dysgerminoma is identical to the male tumor, that is seminoma. Okay, right. Now if you see the histopathological section, you will be able to see so many tumor cells that are arranged in globules. So many compartments are there, and these cells are round to polygonal cells with hyperchromatic nuclei, and you have fibrous septa, and in the fibrous septa one important point you have to notice is there is lymphocyte infiltration. Okay, and sometimes there can also be presence of granulomas. Clear? Right. Okay. Now sometimes even choriocarcinoma yolk cell tumor can be seen mixed with dysgerminoma. A few dysgerminomas can arise from dysgenetic gonads because of the presence of Y chromosomes. Okay, it may even arise from a pre-existing gonadoblastoma as well. Okay, so many associations of dysgerminoma can be seen. Okay, so how will you manage dysgerminoma? Management in stage 1 tumors usually will be done with unilateral salpingo-oophorectomy because these women need to retain their fertility, right? Yes. Then suppose she is a elder woman or it is an advanced stage of the tumor, then you will offer her total abdominal hysterectomy with bilateral salpingo-oophorectomy. Clear? Definitely we will offer lymphadenectomy if she is having any metastasis in the lymph nodes. Then remember, she is a young woman, she needs to retain fertility and she is not willing for unilateral salpingo-oophorectomy. Then what you will do? You will offer chemotherapy, okay, because she is a desire of fertility and she is not willing, you will offer her chemotherapy, okay. But yeah, radiotherapy can also be given, and the interesting fact is these tumors are extremely sensitive to radiotherapy as well. But since they need to be fertile, we are avoiding this radiotherapy treatment in them. Can you understand? Yes. Now, let's also discuss how will be the prognosis of these patients. So, prognosis, dysgerminoma has the best prognosis among all germ cell tumors, and the 5-year survival rate, if you take for stage 1, it is about 99%, and for stage 2 to 4, this is going to be 98%. Clear? Right. Now, let's discuss about the next tumor, that is endodermal sinus tumor or yolk sac tumor. So, endodermal sinus tumor or yolk sac tumor. So, this tumor is derived from the primitive yolk sac. Okay. So, first most common tumor is dermoid cyst. Second most common is dysgerminoma. Now, endodermal sinus tumor is the third most common germ cell tumor. The median age of diagnosis of endodermal sinus tumor is 19 years. And these tumors are highly malignant, okay, and also they metastasis early and invade the surrounding structures, okay. So, these are almost always unilateral tumors, usually 10 to 30 centimeter in size. And if you see the cut section of the tumor, you will be able to see areas of hemorrhage. Okay, you are able to see all these red color, right? So, these are areas of hemorrhage and cystic gelatinous changes are also present. Okay. Then, if you see the microscopic picture, you will be able to see the tumors are lined by single layer of flattened cuboidal cells, okay. Then they have a loose reticular stroma and a central blood vessel present. So, what is this? This is your Schiller dual body. Okay, this is your Schiller dual body. So, we are able to see the cuboidal cells that is surrounding a loose papillary network. The invaginated papillary structure is there with a central blood vessel. Okay, so this is a Schiller dual body that is seen in endodermal sinus tumor, right? Yes. Now, remember, chemotherapy is essential for these patients even from stage 1 of the disease, because I already told you this tumor is going to give a very unfavorable prognosis. Okay, the prognosis is going to be very much unfavorable, and most patients will die even within 12 to 18 months of diagnosis. Okay, even if you check for the 5-year survival, the 5-year survival rate is not as good as the tumors we have seen before. It is only about 60 to 70% in stage 2 to 4. Okay, even if you give so much of treatment, the recurrence rate is also more. Okay, so the recurrence is also more. They will recur mostly within 1 year and they are almost unresponsive to treatment. The recurrence disease is not going to respond anything to treatment. Okay, so no response to treatment. Clear? Yes. Next one is embryonal carcinoma. So, embryonal carcinoma, this is one of the rare germ cell tumor that is arising from the primordial germ cells. Okay, the mean age of diagnosis of embryonal carcinoma is 15 years and more than 50% of the patients will be having hormonal abnormalities. Okay, so these patients can present with some different range of symptoms. They will present with precocious puberty or irregular uterine bleeding. There can be amenorrhea as well as hirsutism. Okay, and the growth of these tumors are generally ill-defined. The cut surfaces will show hemorrhage or necrosis. Here also you have lobulations. Okay, and if you see the histopathologic picture, microscopic picture, the cells will have eosinophilic cytoplasm and a prominent nuclei. Okay, so for treatment we'll be using VAC regimen. VAC is nothing but vincristine, dactinomycin and cyclophosphamide. Okay, sometimes we can even give VBP regimen, that is nothing but vincristine, yes, bleomycin and platin group of drug, that is cisplatin. Clear? And the prognosis free interval after 24 months is going to be 55%. Okay, disease free interval at 24 months is going to be 55%, right? Yes. Next tumor is polyembryoma. So this is also one of the rare germ cell tumor and it is highly malignant as well. Okay, so this consists of embryoid bodies that is morphologically resembling normal embryos, and it can be associated with other germ cell tumors. They show no response to radiotherapy and response to chemotherapy is not no. Okay, yes. Next is choriocarcinoma. See, choriocarcinoma can be classified into two types. Okay, that is, yes, gestational choriocarcinoma, gestational choriocarcinoma. Then we have the non-gestational choriocarcinoma. Okay, so this non-gestational choriocarcinoma is a germ cell type. Okay, now let's discuss about this non-gestational choriocarcinoma. So, this tumor type is usually admixed with other neoplastic germ cell elements, and 50% of them will occur in the pre-pubertal children. Okay, so they will show isosexual precocious puberty with breast development. Okay, so isosexual means same sexual pubertal changes will be seen earlier. Okay, yes. Then they can also present with uterine bleeding, also the growth of pubic and axillary hair. So these neoplasms will secrete what? HCG. Then the adult patient who present with signs of ectopic pregnancy, okay, because she can present with abdominal pain, she is presenting with a increased HCG, means definitely have to rule out it with a urine pregnancy test. Okay, she can be managed by a combination chemotherapy. The regimen here is MAC regimen. So what is M? Yes, it is methotrexate, right? So we are going to give methotrexate, dactinomycin as well as cyclophosphamide, right? Okay. Now we are going to discuss about the teratoma. So as I told already, a teratoma can be mature cystic teratoma or a mature solid teratoma, or it can be a immature type also. Okay, so let's discuss about mature cystic teratoma. This mature cystic teratoma is nothing but your dermoid cyst. Okay, so as I told you already, this constitutes about 95% of all the germ cell tumors, and it is most commonly seen in the second or third decade of life. Okay, this consists of ectodermal, mesodermal or the endodermal components. Okay, for example, the ectodermal components that are most commonly seen are skin of hair follicles. Okay, skin, hair follicles, then sebaceous or sweat glands. Okay, well matured bone as well as teeth and cartilage can also be seen. When you cut open a dermoid cyst, it will be having a foul smell and you will be able to see sticky, keratinous, sebaceous debris. Okay, so if there is an intra-abdominal spill of this content, then it can lead to granulomatous reaction and formation of dense adhesions. Okay, and you have to know torsion is the most frequent complication and it is most commonly seen in pregnancy and puerperium because these women are in the childbearing age group. Okay, so how will you manage? You will manage it by doing a ovarian cystectomy or rarely an oophorectomy. Okay, And remember, patients with stage 1 and stage 2 can also be treated with platinum based chemotherapy or even a whole pelvic radiation. Clear? Right. Now, this is a dermoid cyst, a cut open section. So, you are able to see teeth, you are able to see even bowel like hair and some other tissues are also seen. Okay, this seems like a thyroid tissue, right? Okay. Now, let's discuss about mature solid teratoma. Mature solid teratoma is a rare ovarian neoplasm and it is very uncommon type also. As the name suggests, it consists of very matured tissues. Okay, for example, a well-developed tube. Okay, so it is managed by oophorectomy and these are mostly unilateral tumors. Prognosis of these tumors are excellent. Okay, next one is immature teratoma. We are going to see immature teratoma. So, this consists of 3 germ cell layers, okay, all the ectoderm, endoderm and mesoderm, but it constitutes about less than 1% of ovarian teratomas and it most commonly occurs in the first decade of life. It contains immature neural elements, say glial tissues, immature cerebellar or even cortical tissues. And these tumors are also mostly unilateral tumors and in this tumor multiple peritoneal implants are also seen. So, both the primary lesions as well as the peritoneal implants need to be graded in this tumor and this is mostly managed by unilateral salpingo-oophorectomy with wide sampling, okay, with wide sampling of the peritoneal implants. Okay, the patients who are having the glial component in the implant will have a good prognosis. Okay, so after this, the more advanced lesions will be treated with the VAC regimen. Is that clear? Right. Now coming to the next one, which is monodermal or the highly specialized teratomas. So what are they? We have already discussed, it is struma ovary and a carcinoid tumors, right? So struma ovary is mostly going to be a unilateral tumor and this contains predominantly thyroid parenchyma. Okay, and about 25 to 35% of the patients will be presenting with features of hyperthyroidism. Okay, when you see the gross as well as the microscopic appearance of these tumors, it will be similar to that of a normal thyroid tissue and you have to manage this condition by surgical excision. Is that clear? Right. Next we are going to discuss about carcinoid tumors. So, primary ovarian carcinoid tumors arise in association with gastrointestinal or the respiratory epithelium. This is actually an uncommon type of tumor, can be seen in the post-menopausal age group, and 1/3 of these cases will be presenting with typical carcinoid syndrome. Okay, so the features will include, yes, skin flushing can be there, or there can be chronic diarrhea, or they will feel difficulty in breathing also. Clear? And remember, these tumors also produce 5-hydroxy-indole acetic acid. And what is the management? Yes, again, the management is by excision. Clear? Right. Next, we are going to discuss about the sex-cord stromal cell tumors, right? So, it is sex-cord stromal cell tumors. So, we are going to discuss some of the common variants of this group first. That will include granulosa stromal cell tumors like granulosa cell tumors, thecoma, fibroma, and the second one is Sertoli stromal cell tumors. Now, this is going to constitute about 70%, which is nothing but the Sertoli Leydig cell tumor. And the next one is sex cord tumor with annular tubules. And finally, we have the gonadoblastoma. Okay, we have the gonadoblastoma as well. Clear? Yes. Now, let's discuss about the sex-cord stromal cell tumors in general. Okay. So, these tumors arise from ovarian matrix. Okay. And they are mostly hormone producing tumors. Okay. Most of them are hormone producing tumors that will produce either estrogen or androgen or even both. Okay. This is one of the rare type of ovarian malignancy constituting less than 5% of germ cell malignancy, but it can occur in all ages. Okay. So, what will be the clinical features you will expect? So, clinical features will include, yes, there can be abdominal mass or pain. Then, since they are hormone producing tumors, there can be isosexual precocious puberty, or because of the androgen, there can be hirsutism or virilization. And the postmenopausal women will be presenting with bleeding because of androgen excess. Okay, so all these things can happen, right? Now, the final diagnosis of this tumor should be made by histopathology. And remember, most of these tumors have an interland growth and they are unilateral and localized tumors. Okay, so yeah, what will be the primary mode of treatment? What will you do? You will go for, very good, you will go for removal. So, you should offer a complete surgery, that is total abdominal hysterectomy with bilateral salpingo-oophorectomy if they have completed their family. And in young patients who wants to retain their family, you can even offer unilateral salpingo-oophorectomy alone. Okay. Suppose the patient is in advanced stage, say they are in stage 2 to 4, then you have to give them adjuvant therapy. Okay. So, the adjuvant therapy we choose here is BEP regimen. Okay. BEP regimen that will be given for 3 to 4 courses. Okay. So, this is a first line chemotherapy that is used, but otherwise you have to know that radiotherapy has a limited role. Okay. So, what is BEP? Bleomycin, etoposide, cisplatin, right? Yeah. Now, prognosis of these tumors is excellent because the tumors will be discovered early because of the hormone producing nature, and also it will be confined to only one ovary. Is that clear? Right. Now, next is granulosa stromal cell tumors. Okay. So, this will include the granulosa tumors, that is theca cell tumor as well as the fibromas. Okay. So, this can occur in any age group, say reproductive age group or perimenopausal age group or even postmenopausal age group. Okay. However, the tumors seen in reproductive age are more common, and gross feature of these tumors will be showing varying appearance. Some tumors are solid tumors, and as well as cystic tumors can also be seen. And cut section of these tumors will show that is filled with fluid or blood. Okay. You have two subtypes of granulosa cell tumor. One is adult granulosa cell tumor, and the next one is juvenile granulosa cell tumor. Okay. So, adult granulosa cell tumors constitute about 95% of the cases, whereas juvenile granulosa cell tumors constitute about 5% of the cases, which occurs in the first 3 decades, that is juvenile granulosa cell tumor. Okay. Then it produces hormones, and especially the estrogen hormone is predominant here. Here any hormone can be predominant. It can be estrogen, it can be androgen, or it can be both. Okay. And even progesterone can also be seen. Next one is there is abnormal endometrium in these patients. Okay. So, there can be endometrial hyperplasia or even endometrial carcinoma can also be seen. Whereas in juvenile granulosa cell tumors, you will see sexual precocity with the development of breast, pubic hair and axillary hair. So, in these patients, you have symptoms like vaginal bleeding, whereas in this group, you have irregular uterine bleeding. Okay. So, in the first group, these tumors are indolent, whereas in the juvenile group, these tumors are aggressive. Aggressive in the sense there will be even death within 3 years of diagnosis. Clear? Right. Now, let's talk about the histological features of these tumors. You will be able to see fibrothecomatous components. Okay, fibrothecomatous components are seen. The cytoplasm is scanty. Okay. So, there are a specific type of bodies called Exner bodies, which are common. So, these are nothing but cells that are arranged in clusters or rosettes surrounding a central cavity. Okay. So, here you have central cavity. Okay, you have empty space. You don't see a blood vessel here. If you see a blood vessel here, then it is a Schiller dual body and it is seen in endodermal sinus tumor or yolk sac tumor. When you see nothing but the cells are arranged like this, okay, the red thing is not seen, okay, that means it is a called exner body and it is seen in granulosa cell tumor. Clear? Right. Now, you have to remember these tumors are mostly unilateral, so you can offer unilateral oophorectomy and management can also include radical surgery or chemotherapy if they present in advanced stages or in older age. Okay. So, the prognosis of 5-year survival rate is for stage 1 either adult or juvenile type, it is going to be 90 to 95%, whereas for advanced stages, that is stages 2 to 4, the prognosis is going to be only 30 to 50% because we have already seen the juvenile type is going to be more aggressive, right? Yes. Now, let's discuss about the Sertoli-Leydig cell tumor. Sertoli-Leydig tumor. This is a Sertoli cells where they are seen in the male testes. So, these are male hormone producing tumor and these tumors are rarely bilateral. So, most of them are unilateral tumors only and they are seen in the 3rd or 4th decades of life. Approximately 70 to 85%, okay, 85% of the women will present with abdominal mass definitely, and it is a male hormone producing tumor. So, what will be there? Androgen will be excess, so the patient will be having virilization, okay, and the menstrual compliance will be like she will have oligomenorrhea, okay, even amenorrhea also, okay, all the female features will come down. So, there can be breast atrophy, clitoromegaly, deepening of voice and also a receding hairline, okay. So, what will you measure here? Testosterone. So, serum testosterone becomes high, okay, as well as serum testosterone androstenedione ratio will also be elevated. Clear? Right. Now, when you see the gross appearance of these tumors, it will have solid yellow color and there will be lobulations. They are well differentiated tumors only, okay, they are clinically benign also. So, now let us see about the management of these tumors. Suppose if the female is a premenarchal female or a young female, you will offer her a unilateral salpingo-oophorectomy. Okay, so it is offered when she is a young premenarchal female. Also, when the stage is also less, stage 1 disease. Okay. Suppose if the woman is old or of a higher stage, then what will you offer? Again the same story, right? Total abdominal hysterectomy with bilateral salpingo-oophorectomy. Okay. So, how will be the prognosis in this patient? So, prognosis depends upon the stage as well as the tumor grade of differentiation of the tumor. So, in stage 1 tumors, the rate of survival will be about 90%. Clear? Yes. And with progressive stage, the rate of survival decreases, Right. Now let's talk about sex card tumor with anal tubules. Okay, that is SCTAT, sex card tumor with anal tubules. So 2-3 points only about this tumor. Okay, so this is a unique ovarian tumor. So it appears as a histologic intermediate between granulosa cell tumors and sertoli cell tumors. And then these are usually unilateral, seen during 3rd or 4th decade of life. Clinically, they can be managed like the other STDs. Okay, other sex card stromal cell tumors. Right. Next one is gynandroblastoma. So this is a rare gonadostromal tumor that contains unequivocal granulosa cell elements that are combined with Leydig cells and tubules. So this can also be associated either with androgen or estrogen production and low grade malignancies. Okay, that is depends upon the component of the malignancy that is present. Clear? Right. Next one is we are going to discuss about one important part of ovarian carcinoma, metastatic tumors to ovary. Okay, so metastatic tumors to the ovary. Okay, see, the ovary is going to be the one of the most frequent site of metastasis from primary carcinomas. Okay, so if you see, approximately 10% of the ovarian tumors are not primary in origin. Okay, so they are going to be metastasis only, and it usually comes from the carcinoma endometrium. Okay, it may be difficult to differentiate between a metastatic endometrial carcinoma that is present in the ovary and a primary ovarian tumor. So there are 4 possible ways of spread to the ovary. How it comes? Either a direct spread, or it can come by surface papillation, or the lymphatic metastasis, and then the hematogenous spread. Now among this, the lymphatic metastasis is found to be the common route of metastasis to the ovary, because the upper gastrointestinal tract commonly drains into the lumbar group of lymph nodes. Okay, so the ovary also is linked to this group of lymph nodes. So this happens to be a common channel through which the metastasis can happen. Okay, and one more thing is the non-gynecological tumor which is metastasizing to the ovary commonly is the adenocarcinoma colon. So this is one of the latest report, and the next one is breast carcinoma. Okay, so if you see the gross picture of this metastasis, they are usually solid, but sometimes, yeah, partly cystic tumors with hemorrhage, necrosis can also be seen, right? Now the term Krukenberg tumor should be reserved for metastasis that contain significant number of signet ring cells. Okay, in a cellular stroma that is derived from the ovarian stroma. Signet ring cells are the clear cells, vacuolated clear cells. Okay, so let's summarize how to follow up these patients who present with a ovarian neoplasms, whether it is a benign tumor or malignant tumor, whatever it is. Okay, so first you have to offer them tumor markers, that is AFP, LDH, HCG and CA125 like that. And if they fall in the premenarchal age group. You have to check the mass size. If the mass size is more than 2 cm or if it is less than or equal to 2 cm but with positive markers, then you will do a karyotype and offer them surgery. Clear? If they are postmenarchal females, okay, if they are postmenarchal females, then you have to see whether it is cystic, then size should be seen. Okay, size if it is less than or equal to 8 cm and you have negative tumor markers, then you can advise them with hormonal suppression for 2 months. This can reduce the size of the tumor and clinical follow-up can be done. Clear? Suppose if the cystic size is, if it is more than 8 cm and it is solid or there is suspiciousness of carcinoma, or if you have positive markers, then you have to look for the size. If the size increases or there is persistence, in this people also you can offer hormonal suppression for 2 months. Suppose if the size increases or there is persistence, then you can go for surgery. Clear? So this is to know about the cutoff, especially the size of the mass cutoff for premenarchal and postmenarchal females and what are the tumor markers you can give. Okay. So this is all about ovarian carcinoma. I think we have discussed in detail about the various types of ovarian carcinoma, not even skipping a single type. So hope this video would have been helpful to you. So until we meet in the next video, take care, happy learning, keep going and bye bye.